about trauma triage and their project for on a pan-provincial basis. Oli, you know from this morning, he's also a star tonight on TV. Tonight. And Wilson is one of our regional medical directors as well as an emergency physician at Vancouver General Hospital.
I figured I'd use this because Oli's taller than me, and it just makes it easier. You know, over lunch break, I had a couple of thoughts. Now, I'm gonna walk around a little bit just because it's easier for me to see the screen. But John had mentioned that he wanted to stay on script for most of this day. And so that was my total intent until Dave gave his talk just earlier about trauma systems. So hopefully I don't go on a little bit of a sidetrack here, because it strikes to a lot of things that we're doing in collaboration with TSBC, but it also sort of builds a picture of the collaboration that we're doing for stroke and for all these other entities. And this is just one small piece. And so provincial trauma triage and destination guidelines, they're not new. You know, as everyone in this room sort of knows, they've been around for a long time. And the difference, or the reason why we're actually presenting this today, is really to kind of share some of the experiences that we've had in putting this together, some of the challenges that we've had, some of the problem solving things that we've had to go through to sort of get to this point, and then also to sort of give you a sense of what's in the work in the future for us, because not only is this a evolving and continually changing document as our systems evolve, there's still a lot of work to be done, and this is just the first part of it. So without further ado, we're going to talk a little bit about the destination guidelines and just review them just for everyone's sake so that we're all on the same page. And then towards the very end, which is the meat of this discussion or this talk, is really about the documentation, the data, and the feedback, and the process moving forward. So I'm going to pass this over to Oli right off the bat, and there's no better way to start a presentation than illustrated through a case.
Maybe I'll take the mic too. Get nervous if I stand at a podium in one spot too long. So I'm going to do my best to paint a picture. Hopefully this is going to be a familiar picture for many of you in the room. This one, the big one, the big green arrow pointing the other way, yeah. And this is basically the root of what we do. And with respect to trauma calls, we're dispatched to the scene of a rollover, MVA, 120 kilometers an hour on the highway. And this could be a highway anywhere in Canada, in any jurisdiction. But we get a lot of information off of these first little tidbits of as the calls come in. And we arrive on scene. Again, this is something we maybe have seen before. And there's a couple clues right off the bat that start telling us and leading us down a road to hopefully a decision about major trauma. What does that mean, and where does this patient have to go? So I'm going to walk you through this. We've got one patient on scene. Again, this is straightforward stuff we already know very well. The scene is safe. And our initial assessment tells us a few things. This is a 50-year-old man, a young man, driver restrained with airbags. As you can read off here, complains of some chest pain, abdominal pain, and pain to the pelvis. Looks unwell to us. Is in distress and is a little bit confused. We do a rapid trauma survey. The patient is protecting his airway. He's got bruises to his forehead. There's chest pain on palpation. No flail or paradoxical movement with breathing. Significant tenderness to the abdomen on palpation. Pelvis feels unstable when we gently assess it. No pain or deformity to the femurs. Moving all extremities to command. GCS is 3, 4, 6. This is hopefully, again, pointing us down a road. This is telling us a bunch of information that we intuitively already know. We're getting highly suspicious that this is a very sick trauma patient. We get a little bit more data that helps support that initial assumption. We've got a heart rate of 130, patient is tachypneic, hypoxic, and look at that blood pressure, 80 on 40. So we start making some decisions. We're going to load this patient, we're going to go. We're going to minimize our care to what's absolutely necessary for this patient at this time. We're going to administer some O2. We're going to extricate, full spinal motion restriction, pelvis immobilization, and we're moving towards the ambulance, and we're on our way. We're going to begin our transport, maybe start some fluids, TXA, and notify the hospital. Now, we've come to a decision. Intuitively, we've figured out and identified that this is probably a very sick trauma patient and we need to get to them in the hospital right away. But for us, we need a system that's going to help inform that decision. And this is what we're basically building here with this document. And we need a system to help inform where that patient needs to go and where they're going to get the best care for it. And this is our provincial pre-hospital triage and transport guidelines.
So I'll walk us through this a little bit. The document, as Dave showed before, is available for anyone who's actually interested in getting the document. And also, this is more so for our paramedics too. It's available in the handbook. And so it's under the treatment guidelines. It's under either the adult or pediatric guidelines. There's a section for major trauma there. And under trauma triage guidelines, you'll actually have all the steps for trauma triage, as well as the destination guidelines and the guideline document in its entirety for review. So this is just something that if anyone is interested later after the talk, you can access this and take a look at what we've done. But there are three main concepts. Now again, the whole idea of trauma triage and destination protocols, they're not new. But three things that we have identified that were difficulties for us or challenges for us. And so the introduction of this document really tries to look at these three things. So the first is lead trauma hospitals. And this is a new terminology that we actually adapted from our Ontario colleagues. Now, in BC, based on the geography and based on the availability of resources, most trauma hospitals are not level 1 or level 2 trauma hospitals. So traditionally, trauma hospitals are just level 1, level 2, and that's how they're designated. But in a rural area, the trauma hospital may be something like a level 3, potentially a level 4, but they need to be acknowledged that they are the designated trauma center serving that regional catchment area, right? And so we don't want to discount what these hospitals and what these programs are doing, even though they're not sort of a level 1 or 2 trauma center. So we've used this new terminology to describe all hospitals that are going to be the hospitals receiving trauma on a regional level. This is the list of all the lead trauma hospitals that TSBC has defined. And as you can see, a majority of these are not level 1 and level 2. We want to standardize the major trauma definition. Now, in the past, because we've got multiple health authorities, multiple regional trauma programs, the physiological and anatomical criteria that sort of define major trauma was different. And that you can sort of see leads to communication sort of difficulties, or when we're not talking the same language, it makes it hard to communicate. And so the idea of this is that we formalize and standardize what we define as major trauma. So here we've got the presence of any of the following. So any physiological criteria or anatomical criteria that meet the major trauma definition, that is what we consider a major trauma patient. And specific mechanisms that place a patient at high risk for major trauma, that also constitutes into the subset. And so these are all based off of the CDC field triage criteria back in 2011. I'm not going to go through them in detail because I know everyone in this room is very familiar with them. The only caveat here is that we've amalgamated the adult and pediatric sort of criteria onto the same algorithm. And the reason for this is twofold. One, so that it's a one-stop shop. So it's easy for you to actually access the information. You're not looking at multiple guidelines or protocols to sort of look for adult versus peds trauma. And at the same time, peds trauma is a very low incidence sort of population. And so to be able to be familiar with pediatrics on a general basis, when you look at the overall trauma algorithm, it's already on there. So every time you look at the algorithm, it serves as a reminder for pediatrics. The only difference between the criteria, both in step 1, step 2, step 3, is the addition of this one line, which is here. Now, a majority of our paramedics in the province are PCP, and so in sort of collaboration and through advice from the pediatric trauma advisory group, we've, rather than just using the traditional all population physiological criteria, the group has suggested and advised to sort of say that we should be using abnormal blood pressures, heart rates for age for the pediatric population. And so we'll see how this plays out in terms of our data when we collect it to see whether or not this over triages versus adequately triages the pediatric patient population. But this is a work in progress. Again, anatomical criteria are standard, and same thing with the mechanism criteria. Same thing with the special circumstance, so special considerations or circumstances. So these are patients that we would have high considerations to be transported to a lead trauma hospital, but not always depending on certain circumstances. So this is what it looks like, and in its entirety. You've got the initial part of the triage, which is your failed airway and your traumatic arrest. Then moving on to the step 1 and step 2 and step 3, physiological, anatomical, and mechanism criteria. So noting that your the recommendation is to actually transport all step 1 and step 2 patients to the lead trauma hospital or pediatric lead trauma hospital, and then a strong consideration to transport these patients to a lead trauma hospital or pediatric lead trauma hospital if they meet mechanism criteria. We know that geography, again, and distance and weather influence our transport decisions. So within each regional trauma program, there are certain specific points which will help paramedics make decisions about whether or not to actually go to the lead trauma hospital if the transport distances or the time is too great. So going back to the trauma call, this is no failed airway, patients not in traumatic cardiac arrest, they meet step 1 criteria or physiological criteria for major traumas, so they're transported to the lead trauma hospital. So I want to talk a little bit, and this is where all the work upcoming, or this is where all the work is going to happen in the near future, and this is a documentation data and feedback section. Our trauma systems evaluation in the past and presently relies on sort of indirect measures. And so we try to glean a subset of major trauma patients based on paramedic documentation. So in the past, before we've had electronic health records, we would have to rely on data that was handwritten, then gets transcribed by an exterior company, then the data gets sent back to us, and then we'd have to try to make some meaningful interpretation of it. And so we identified during that process several issues. So the first is just documentation in itself. So is it complete and is it accurate? For some odd reason, only 85% of vital signs were actually documented when we actually looked at the paper PCRs when we first started. So that was an area that we want to focus on. Identifying and documenting significant injuries. Now, you can imagine if things are free text. So if you have a examination or like a physical examination section, and everyone writes something different. So they document differently, they notate things differently. It makes it really hard to then understand what the actual true injury patterns are. In the past, we've also used paramedic impression codes to try to identify patients who would be at risk or have sustained major trauma. But even this is an interpretive sort of exercise. When a patient says, or their impression code is multi-trauma, is it rolled ankle, bumped head, and a little bit of bruise on the elbow versus smashed pelvis, significant intra-abdominal injury, a TBI? It's hard to really know. The last thing is that none of this data was really linked because we had no subset of population to link it to. So that really leads us to what's upcoming. Now, Dave gave a great talk this morning about the trauma registry and sort of how robust it is. So that's pre-existing already. With the inclusion of the new SIREN system or electronic health records, we want to prospectively have paramedics identify major trauma patients and identify and document that as well. So the goal is then these two entities, or these two subsets of populations are now linked together. Just simply by this, we should be able to look at something that we were never able to look at before, which is a true measure of over triage and under triage. We used to look at under triage as a patient who presented to the hospital and then was transferred out from the initial center to a level 1 or level 2 trauma hospital within the first 24 hours. But we know in our system that patients may or appropriately be presented to a regional lead trauma hospital now, so like a level 3 or level 4, and then also appropriately then transferred out because they need a higher level of care within 24 hours. So we weren't really able to truly measure under triage in the sense. But if we can prospectively identify our own cohort of trauma patients, we will be able to understand when the two data sets the goal is that we get to this point at some point. So again, this is the collaboration, and this is much thanks to Trauma Services BC, much thanks to all the regional trauma programs, much thanks to our staff in-house here to get this up and running. And so the goal is that we want to use SIREN to collect data. That's data that we will use, and Oli will present this in a second, but the electronic health record platform allows us to actually create forms that that we can sort of use to collect data that's actually relevant, that we're actually going to act upon, and provide the adequate feedback when it's done properly. So again, that'll be linked to the data with TSBC. So I'm going to leave this to Oli for a second here, and Oli's going to just run you through what the actual documentation looks like on the electronic health record platform.
Thanks, Wilson. So in British Columbia, we recently moved towards an electronic patient care report using SIREN. We're learning from this process. We as paramedics, we don't like change all that much, but it is rolling out, and there've been a few bumps in the road, but I think this presentation just highlights how important that information that we gather out of that this process is. And I'm going to walk you through one piece of this, and this is our mandatory major trauma field. So when we go into our SIREN, the EPCR, we're going to be asked a question. Does this patient meet physiological criteria for major trauma? This is a forced mandatory pick list. It's a single select. And if not, you just press no and then you move on with the rest of your documentation. If it does, it's going to open up the rest of this pick list. And we're going to ask a few specific questions to make sure we capture the information regarding major trauma so that it can inform everything from our practice moving forward, our appropriate levels of triage, and as Dr. Evans mentioned earlier, if we're talking about a system of care, how we're doing, or what we're doing in the pre-hospital environment, how does that meld with it? And the next section of this is major trauma injuries suspected. And we'll just go click through a couple of simple, again, forced mandatory pick lists. And then we'll ask a couple more questions about mechanism of injury. Finally, we want to gather a little bit of information on interventions to the airway, spinal motion restriction, breathing, circulation. And to illustrate this, I'm going to walk through our trauma case as well. So the first thing is date and time. Now, we don't always have that exact time of the incident, so we're allowed to override this because hopefully we can gather that. That is very important first step in what we're doing, but we're going to allow you to override this if you have to. Second question is, did this patient meet the physiological criteria for major trauma? And in our case, yeah, this patient did. So we're going to select the major traumatic injury suspected. We've got unstable pelvic fracture. And if, just to illustrate this, this wall, or this pick list gets a little bit bigger, and we've just summarized it right there. Major traumatic mechanism involved, click, so we're on our third click. Airway intervention needed, none, 5 clicks. Full spinal motion restriction, oxygen applied, IV access, a couple more ticks, pelvic binder, TXA given, crystalloids. And this is going to generate a very basic data report for us that is going to be linked to the trauma registry directly for, well, the first time ever. And this is really going to inform all of the practice that we're doing, how we're allocating our resources, and how we're building our care moving forward. Also give us the opportunity to provide some individual case reports for feedback to the paramedics, and this is, I think, in all areas we're trying to encourage this as well.
And that's pretty much it. I just want to bring up one more thing, and this sort of came to mind as we talk about education and practice updates. And this came to mind when during the last trauma talk. But going back to our documentation, for the first time ever, if we can actually if we're able to link our pre-hospital records to patient outcomes, we'll actually know which areas within the service that we need either more education on or revision of what we do. So an example here would be, let's say a pelvic binder wasn't put on by this patient, and the outcome data shows that there was an unstable pelvic fracture in-house when we get the data linkage. And we know that over the course of time that we're not putting pelvic binders on about 15% of patients who have traumatic or unstable pelvic injuries. So this would be then feedback for us as a service to go back and do like, either a practice update or individual paramedic education, both in person and sort of as a service. And this sort of educates your practice sort of moving on. So, yeah, and acknowledgements here are really, again, mentioned. People in-house here are CMP group, all our paramedic practice leaders or educators, and sort of leaders, whether or not they are formally leaders or they're leaders out in the field by example. Within TSBC, Dave and the rest of the executive group, one person who is no longer with Trauma Services BC, but has been a huge help with this is the project manager, Vide, and then the rest of the regional trauma groups in the HSA itself. So we're open to questions if you have time.
No, you're not.
Moving along.
Steve has coached me. Questions at break. Thank you very much, guys.